All right, everybody, it is 12:01. My name is Grace, and I'm so happy to welcome you to the final webinar of our 6th annual Cannabis and Practice webinar series, hosted by the Washtenaw County Health Department and the Livingston County Health Department in partnership with the Washtenaw County Medical Society. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide range of backgrounds and are experts in their respective fields. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. This live webinar has been approved for 1 social work continuing education clock hour, 1 specific McBAT credit hour, and 1 credit hour of CME. If you are requesting any of these continuing education credits, please be sure to stay until the end of the webinar to fill out our post-webinar evaluation survey. Please be sure to provide your name and email address to ensure that you receive certification for your attendance. This webinar is being recorded. The webinar recording and presentation slides will be available on our website at washtenaw.org/marijuana in the coming weeks. Before we get started, we ask that all questions for our speaker be asked through the Q&A function, which can be found at the bottom of your screen. We will have time at the end of the webinar for the speaker to answer questions. I am pleased to introduce today's speaker, Dr. Leslie Lundahl. Dr. Leslie Lundahl received her PhD in clinical psychology from the University of Wisconsin and then completed postdoctoral training in behavioral pharmacology at Harvard Medical School. Currently, she is a professor in the Substance Addiction Research Division within the Department of Psychiatry and Behavioral Neurosciences at Wayne State University School of Medicine. Her research, which is funded by the National Institute of Drug Abuse, focuses on understanding and treating addictive behaviors. She has been involved in many studies of behavioral and brain processes thought to underlie substance use disorders. Currently, she is investigating potential risks and benefits of cannabinoids used as therapeutics. In her clinical practices, she specializes in using behavioral therapies to treat adolescent and adults with substance abuse and comorbid psychiatric disorders. Dr. Lundahl is committed to teaching and training graduate and medical students, as well as community treatment providers in assessment and treatment of substance use disorders. If we could move it to the next slide for our CME disclosure. None of the planners or speakers for this educational event have any relevant financial relationships with ineligible companies to disclose. I am pleased to pass it off to Dr. Lundahl. Thank you again for being here, everybody.
We are not at the right slide. Sorry about that. Thank you, everyone. Thanks for that introduction. I'm happy to be here today to talk to you about adolescent cannabis use. Financially, sadly, I have nothing to disclose. And objectives for today's talk are to go over some of the current trends in adolescent cannabis use, and we'll focus a little bit more on newer formulations and routes of administration that teens are using. We'll talk about some of the effects of THC exposure and some of the potential risks of cannabis use, specifically during the adolescent years. And finally, we'll wrap up by talking a little bit about screening intervention for adolescent cannabis users. So I'll start with a little epidemiology. These are data from the most recent Monitoring the Future study, which is a survey study conducted annually by the University of Michigan, and it goes over substance use and attitudes towards substance use. And what I wanted to show you here is this goes back from 1975 up until the current year. And as you might imagine, back in the heyday of marijuana use or cannabis use, we'll call it, there was certainly the rates were much higher. They came down significantly around the late 80s, early 90s, and then started to creep up again in the 90s. And they've stayed pretty consistent across time. What I want you to notice here is, one, the pandemic restrictions. The data from 2020 were collected before any kind of shutdown. So 2021 is where we see a drop off in use. And a lot of that is because, as I'm sure most of you know who work with adolescents, adolescent drug use and cannabis use are very opportunistic. And so if you are not allowed to leave your house or you are with your parents all the time, you're not able to use cannabis as much as you would like to. And especially for these 10th graders here in the blue line, there was definitely a drop. It's starting to recover a little bit, but we haven't really seen it pop back up. And part of that might be that kids who would have initiated cannabis use during this year have not. And so though they are not reflected in these numbers yet. But even with the drop off, what I want to say here is that still a third of 12th graders, almost a third of 12th graders, about 20% of 10th graders, and almost 10% of 8th graders still report using cannabis in the past year. So this is cannabis use in the past year. The other thing I'd like you to notice is that 2012 is when we first had the first couple of states legalize medical marijuana, and then over the years, of course, recreational cannabis use. We haven't seen a huge uptick that has accompanied legalization. And part of that is because teenagers have never really been concerned about whether it's legal or not, right? It's not legal for them anyway, because they're not 21. And so we haven't seen a huge rise there. Cannabis vaping is relatively new, and this was added to the survey. I believe this is 2016. And what I want you to notice here is, remember from the last slide, slide, we had 29% of teenagers who were using cannabis in the past year. 20% of those folks are using it through vaping. So they're not smoking joints or blunts or bongs or doing any old school stuff like that. They are vaping. And the reason that's a concern is that vaping cannabis generally involves vaping or using really high potency or high concentrated THC products. And we'll talk more about that in a second. This is just another way of looking at it. This is from the National Survey on Drug Use and Health. And these are kids who've used in the past month, so a little bit more regular users. And in the 12 to 17 year age group, what I want you to see here is that of the kids who are smoking or who are using cannabis, 55% of them are vaping. So again, these are kids that are using these high potency products. These are not kids that are just smoking cannabis flower. So that's a concern that we will also talk about in a second. And then my final epidemiology slide, these are trends in perceived availability and whether there's risk of use. So this is asking 8th, 10th, and 12th graders, if you wanted to get a hold of some cannabis, how hard would it be for you? And then what percentage of them say that there's great risk of harm if you use regularly? Do they view it as potentially harmful? And what I want to point out here is the relationship of availability and risk to rates of use. And so what you see here is going back to the mid 70s, availability has never really been an issue, right? So up to here, about 90% of 12th graders will say, or actually these are 8th, 10th, and 12th graders together, will say that if they wanted to get some, it'd be really easy for them to get it. And it dropped off a little bit again after the COVID shutdown, but it's still 70% of them are saying it'd be fairly easy for them to get a hold of. You'll see that the perception of risk went way up over the early 80s and up until early 90s, and then it's come back down. And this, I think, is where we see effects of legalization, that if it's legal or it's medicine, it must be safe. And so we see a really precipitous drop in perception of harm. And then what you'll see here is there's an opposite relationship between risk and use. So as the idea that it's risky goes up, use goes down, right? But as they start to come together and risk goes down, the use starts to go up. And so this is what we're seeing here. And so I think this is where we might see, like I said, the effects of legalization contributing to increased use is not through increased use per se, but through the decrease in perception of risk. So why are we worried about adolescents specifically? Really, it's because adolescence is when most kids start to experiment with drugs. And as we just saw, the changes in the legal landscape around recreational use laws is changing perceptions about availability and risk. And so that, I think, is creating sort of a storm for adolescents. We know that adolescence is a time of extreme vulnerability to brain insult. It's a time when neural substrates that underlie development of cognition is most active. There are a lot of neural and behavioral changes occurring in the brain, both to structure and function. And because cannabis has effects specifically in the frontal cortex, it can disrupt neurodevelopment. And because of that, can interfere with all the social, psychological, and academic function to a greater degree compared to cannabis use in later developmental periods. So that's one reason why we are very worried about it. I'm sure you know a lot about cannabis already, so I'm going to do a very quick review. The cannabis plant, Cannabis sativa, contains hundreds of cannabinoids. The ones that you probably are most familiar with are delta-9 THC or THC. THC is the primary psychoactive component of the cannabis sativa plant, and it's thought to be what contributes to this sort of feeling of intoxication or high. And cannabidiol, or CBD, is also a cannabinoid. It's thought not to have psychoactive effects, although some studies have shown that it does have some anxiolytic and sedating effects. So I'm not sure that we can keep calling it not psychoactive. And then when I talk about potency of cannabis products, it's really concentration of THC we're talking about, which refers to the content of THC in each unit of weight or volume. So usually it's expressed as a percentage. So if you're using cannabis that's 20% THC or 30% THC, we call that potency, but it's really concentration. When you're consuming it, though, like if you use it in a drink or as an edible, we usually refer to it as milligrams. So as you probably know, there are hundreds of varieties of strains or strains that are cultivated that are sold on the regulated market and also on the street. We know that THC binds specifically to cannabinoid receptors, specifically CB1 receptors are found throughout the central nervous system, but the highest concentration is in the brain, and most of it is in the nucleus accumbens here, which is the brain's reward system. Also in the hippocampus, which is why cannabis can affect memory and learning. In the amygdala, which kind of controls fear and emotion, hunger and hormones, the cerebellum, which is why there are effects on balance and coordination when you're high. But more specifically in the prefrontal cortex, which is where your judgment, your ability to plan ahead, to understand consequences, to inhibit risky behavior, all of those are centralized there. And so the reason I'm showing you this is that all of these little yellow dots are CB1 receptors. And of all the substances of abuse, cannabis just has diffuse effects to the brain. So in terms of drug effects, you get the munchies, you can, water can make certain noises that are different, music sounds better, your friends are funnier. It has all these different kinds of effects, and it's because it binds to so many different areas within the brain. And there's also some research that suggests that the THC binding to the CB1 receptor is actually greater during adolescent years than during adult years. So let's talk a little bit about acute THC effects. And so these are the effects that you would see immediately after using. The most consistent side effect of cannabis use is a rapid heart rate increase of about 20 to 100%. And this is why there are risks, there are cardiovascular risks, especially for older folks who are using cannabis. There are mood and behavioral effects. Basically, you get high. It's a pleasant, sort of relaxing feeling, a sense of well-being. The hallucinogenic effects are quite mild. It's nothing like a true hallucinogen like LSD or peyote or acid, something like that. It's more of a mild perceptual distortion. So things might sound, look, or taste a little bit better. There's disrupted motor coordination and balance. And so there are a lot of new studies coming out. Obviously, a big concern is driving while under the influence of cannabis. And specifically, what we know is that cannabis can narrow the visual field and slow reaction time. So if you think about a teen driver, one, they're inexperienced. Two, if the periphery is somewhat limited, they may not see cars coming from the side. And when they do, their reaction time is really slow. And there are some recent studies showing that the effects of marijuana or cannabis on driving is almost as dangerous as driving with alcohol on board. Another effect is the munchies. Everybody reports getting the munchies when they're high. What am I doing? Okay, I went backwards, sorry. And as the effects start to wear off, a lot of people will report feeling a little bit sleepy or a little bit down as they're coming off the high. We definitely know that when you're high, you're kind of dumb. There are acute effects on cognition, and there's strong evidence of impairment specifically on attention, memory, and learning. You cannot learn anything when you're really high. You're not going to remember it later. And so a lot of discussions I have with my teenage patients is how, getting high before you're studying is not the best idea. There's some evidence as well that there are effects in concentration, judgment and decision-making, motivation, which we'll talk about in a second, and as I just said, motor performance and coordination. And the research is very clear that these effects are dose-related. So the more you smoke, the worse the effects are going to be on cognition. And then finally, a lot of people will report feeling sort of anxious or dysphoric or a little panicky. And the paranoid effect actually seems to intensify with age, which is sort of interesting. And at very high doses or at, if you're using products with really high THC concentrations, you can have sort of an acute psychotic reaction. And this is characterized by paranoia, delusions, hallucinations, or a sense of depersonalization. And we will certainly talk about the link between THC and psychosis in a second as well. All right, so one of the issues that I think is making it more concerning for teenagers to use is that these changes in potency over the years and these different routes of administration carry with them a lot higher risks of their use. So this is one of my favorite slides. These are samples seized by the DEA starting around 1995 here up until about 2015. I put this here because for those of us, and I'll date myself now, but for those of us who were in high school in the 1980s, the cannabis you could buy on the street had about 1 to 2% THC in it. And that has steadily grown up until the present day where it's getting close to 30%. So this is not your dad's or your grandpa's THC. This is a very different drug than it was back in the 80s and the 90s. And the other thing to keep in mind is that most of the studies, most of the data that we have showing the negative consequences or the potential risks of cannabis use are based on studies that use 2 to 4% THC, which is nowhere near the potency of the THC that you can now get on the street or in dispensaries. And so a lot of what we, don't know about, a lot of what we know about the effects really can't be translated to these higher potency products because we really just don't know what those effects are going to be. And then what I did here was just superimpose, these are cannabis concentrates, which we'll also talk about. These are hitting up at 99% THC. So if you can imagine, these contain 3 times the level of THC compared to what you find in cannabis or flower. So when I talk about vaping or dabbing, it's these products that are just super, super high doses of THC. So it's the new cultivation techniques that's allowed these high potency products to come onto the market. As I said, cannabis flower, if you go into a dispensary, they top out at around 30%, which, make no mistake, is still an extremely high concentration of THC. But the concentrates can contain 2 to 3 times the THC than the most potent plant you can find. In Colorado, in most dispensaries, the average concentrate product contains about 62% THC, but dispensaries advertise cartridges that are over 90%. And there are studies out showing that they specifically are trying to develop products that hit up 99 to 99 or 100% THC, which is crazy, just as a side note. So over the last couple of decades, there's been a shift from in teen cannabis use from sort of this idea that we're bored and we were trying something different or we want to experiment to actually needing to manage stress or saying that they're using cannabis to manage stress or deal with painful feelings, maybe self-medicating. And interestingly, studies have shown that the younger you are when you start using, you tend to use twice as often and you tend to use 3 times as much per week. And it's sort of this combination of an early onset use. And when I'm talking about early onset, I'm talking about 13, 14, 15-year-olds. So you combine the earlier onset age with a higher frequency of use and a greater magnitude of use. And those are the effects that tend to have the most impact on executive function, negative impact on executive function. And the executive function, I'm talking about, working memory, verbal memory, and attention. We know that teens tend to seek out the most potent products that they can because they're going to get the greater effects, or they believe they're going to get greater effects. And so when I talk about potent products, I'm talking about these higher THC concentrations. And the modes of use tend to be things like dabbing, where you get a huge bolus of the concentrate at one time, or using vape pens or oil pens. And we'll talk about that in a second as well. So if you were to go into a dispensary and you wanted to buy edibles, you can find chocolate bars, you can find lollipops. Mostly it's gummy worms, things like this, voodoo sours. These are like gummy worms. Newer to the market are beverages that contain this one actually contains 2 to 4 milligrams per can. Most states have a law saying that each serving of an edible can't contain more than 10 milligrams of THC. That's still a pretty, whopping, it's not a whopping dose, it's a healthy dose of THC. However, each bag can have 10 servings. And so you can have 100 milligrams of THC. Most people will report the effects from edibles can be unpleasant because they're unpredictable and they're very long lasting. And oftentimes what will happen is that someone will take an edible, they won't get high. If you're used to smoking cannabis, you'll feel it within the first 20, 30 seconds of taking that hit. But if you take an edible, it often takes 45 minutes or 60 minutes for those effects to kick in. And so people will just take a second one or even a third one. And then by that point, they've had a really big dose of cannabis and it becomes unpleasant. And then they'll present in the emergency room. So let's talk a little bit about extracts and concentrates. These are the products that are being used in these vape pens and oil pens and dab rigs. Extraction methods. So concentrates are made by extracting THC from dried cannabis flower. There's a variety of methods. You don't need to know any of these. We're going to focus mostly on these flammable solvents because those are most common. Usually it's a butane process. And so what you do is cannabis flower is put into sort of a tube-shaped vessel, and butane is pumped through that vessel at really high pressure. And that pulls out the cannabinoids and the terpenes and all the other fun things from the plant material. And then heat is used to evaporate any of the residual solvent. And then they're left, basically what you're left with is the best part of the plant, and it's sort of an amber colored liquid. There are a lot of dangers associated with these methods. One is that there's almost always going to be residual butane in a product. So you're going to be smoking that and you'll get that residual butane, and that's a threat to the user. Inhalation of butane in general is dangerous. Not every manufacturer takes adequate steps really to remove that residual solvent. And on top of this, folks who are sort of DIYing a butane hash extraction, it's prone to explosion, just like a meth lab might be. And so there are certainly reports of this happening as well. So this is what cannabis extracts can look like. I said it's sort of an amber color, and depending on whether the extracted oil from the butane extraction is agitated or heated, you get a different product. So you'll hear about something called wax. And wax is sort of the consistency of, and that sounds gross, but earwax, and that's why it's called that. And that's if you heat this extracted oil, you'll get this waxy thing. If you agitate it, you get something called shatter. And shatter is sort of a transparent concentrate. It looks a lot like a Jolly Rancher candy, sort of a glassy candy. It has a consistency of like a very thin peanut brittle. And most of the extracts are named for their consistency or appearance. And so if you have something sort of runnier, it's called butter. If you have a soft brittle texture, it's called crumble or honeycomb. But these are all extracts. It can be powder, it can be like a coconut oil, or it can be like glassy. And these are all different kinds of concentrates. If you were to go into a dispensary, you'll see that they come in very small amounts because they are so potent. And if you look here, these are 85% THC, 87% THC, 86% THC. And a lot of these places will promote these products as health products. And they have names like Hello Marijuana, Goodbye Anxiety. Another product is Hello Marijuana, Goodbye Insomnia. Or they have, cutesy names like Lemon Cherry Jealousy, Gorilla Cookie Sugar. A lot of these products are very much targeted towards teens with these names like this. A lot of adults are not, really going to be buying things called Strawberry Bomb Sugar. But this is what an extract would look like in a dispensary. So when we talk about vaping cannabis, a vape device for cannabis is very similar to a nicotine vape device, or an ENDS, an electronic nicotine delivery system. And so there are internal coils that are heated by a battery supply, and you insert a cart or a cartridge of vape liquid, which contains THC concentrates. Actually, there are some new ones that can do oil concentrate or flour, and I'll show you some of those in a second. But basically, they come in contact with those heated coils. So it's not combusted like a cigarette. It's not a flame. And it produces an aerosol or a vapor that is then inhaled. So the vapor is produced by heat, not combustion. One thing I want to be clear about is this is not water vapor. This is not the vapor that comes out of a tea kettle. This is an aerosol that contains fine particles that actually contain toxic chemicals. The vapor does disappear instantly. It doesn't have the smell that cannabis does. So because of that reason, it's very easily concealed. Kids can do this very easily in school, in high school, walking through classes, through the halls, on school buses. It's difficult to detect, and you can see why kids would be drawn to this because it is very easy for them to get away with. So a vape pen or an oil pen looks just like a Bic pen. It's about the same size. Here you get a better shot of what an oil cart would be. So this is actually a cartridge for sale down here. It's a very small piece that would snap right into this pen, and then you just suck on the end of this. This is another vape oil pen. So PAX is a company that just came out with a device that you can either use an oil cartridge, or you can crumple up plant material and put it in there and also use it through vape. And this is sort of what it looks like. They're very small, very sleek. Dabbing is a little bit different. Dabbing uses something that to me, and people in my cohort will remember as a bong. Except that what you're doing is you're taking a very tiny piece, a dab of concentrate. This is actually a nail. So this is a head of a nail, just so you get a sense of how small this is. It's a really tiny amount of material. And you put it on you put it on this little heated area, and you use this butane torch and light it up. And then the smoke comes in here and you inhale the vapor. You get a single extremely high dose of THC in this concentrate, just through this single hit. And so these are dab rigs and other devices you can use for dabs. So this is the dab rig. This is where you would heat it up. They now have a portable device. These are the coils here that you would heat the dab on there. This particular device does dab, or you can use an oil cartridge, which you can see right in here. And this one on the right is not a vape, but this is a newer thing. It's an inhaler, an aerol inhaler, and this comes in flavors like grape ape and tangerine haze. It's advertised as providing metered doses to consumers, and this is now available in recreational dispensaries. So inhalers, nasal sprays. So this contains a concentrate mixed with other inactive ingredients to get that mist-like product inhaled through the mouth or even through the nose. This looks like obviously like an albuterol inhaler, an asthma inhaler. So this is sort of the newest thing on the market. All right. So let's talk about some of the consequences of use and some of the potential risks. I feel like I'm whipping through this very quickly, but I'm trying to make sure we're on time. So probably the biggest risk is developing a cannabis use disorder. About 30% of people who use regularly are going to develop a cannabis use disorder. If you start using cannabis before the age of 18, that risk increases 4 to 7 times. About 9% of users will develop a physiological dependence on cannabis, and that number goes to about 17%, again, if you start using during your teenage years. There is a withdrawal syndrome that is seen with cannabis use disorder, and this was not really evidence-based until the DSM-5 came out. Before then, there was sort of up in the air and some controversy as to whether there was a withdrawal syndrome, and that's why a lot of people thought the cannabis might be psychologically addicting, but not physiologically. We now know there is a withdrawal syndrome. It starts almost immediately after cessation of use. In the DSM, it says it can last 2 weeks. Those of us who work with teenagers clinically know that it can go much longer. It can go 4, 5, 6 weeks. The symptoms you're going to see for sure are irritability and moodiness for sure, some agitation. A lot of people will have a hard time sleeping. Appetite will drop off. There'll be some restlessness. Almost everybody reports craving, and that is the withdrawal syndrome for cannabis use disorder. We talked a minute ago about how when you're high, you're dumb. How long do those effects last? There's no general consensus right now in the literature, but reviews of cross-sectional studies have shown that there are some longer lasting effects, and they've been found in 3 specific domains: memory, which involves learning and obviously retaining new information, attention and concentration, response speed, and executive function. And executive function, as I said earlier, is sort of working memory, like if you try to remember someone's phone number, like we used to have to do before cell phones, verbal fluency or decision making. So these are the 3 areas: memory, attention, and executive function, that seem to be most effective longer term. So a question would be, after the high wears off, how long do the impairments stick around? We have a lot more literature in adults showing that there's some recovery that you can see after a few days of abstinence, and generally people return to baseline by about 30 days of cannabis abstinence. But with adolescents, we don't know. And so one of the questions would be, if you have a teenager who says, I'm really good, I only smoke on Friday night or Saturday night, but what are they like in school on Monday? Have they recovered? Are they able to concentrate and pay attention and learn new information? And as I said, there are a lot of contradictory findings. Some studies have shown that there's no lasting deficits after 72 hours. So would that be a lasting deficit? Or I would probably call that more residual intoxication, that if the high lasts a couple of days, 3 days, and then wears off. Others have found that there are persistent deficits after a month or 2 in at least one of those domains. Most studies show at least a partial recovery after 30 days. So it does sort of look like there might be recovery for adolescents, but it's not as quick as with adults, which is interesting. Another question would be, is earlier onset use worse than later onset? And there have been several pretty comprehensive reviews that are looking at the impact of cannabis use. And the general consensus here is that the earlier you start, the riskier the use is going to be. And so specifically, we've seen relationships between use and reduced performance on spatial working memory and verbal and episodic memory, complex attention, executive function, and processing speed. And we have been able to note through brain imaging studies, there are changes in brain structure and function that are going to affect some of these domains. And so really what this might mean is that there's going to be some difficulty learning. It may be the kids aren't performing at levels that you might expect them to. And they may have to work harder to achieve the same grades as the control subjects in these studies. And so these would be kids that haven't smoked cannabis or started smoking later in 18, 19 rather than 14 or 15. So specific cannabis or specific changes in the brain, we know that it has to do with structure and function, and it's probably those changes that underlie the link between use and cognitive consequences. And I'm not going to go into very specific stuff. I know there was a seminar earlier specifically on the cognitive changes. There's also some evidence of functional compensation, and this is where one part of the brain might step in to try to make up for a different part of the brain that's more affected. And so, adolescents' brains obviously have a lot more plasticity and can do that. But sort of the effects on neurocognitive functioning are really seen with kids who are using at earlier ages. And so what that means is that you're going to see some effects on academic performance. And what we know from the literature is that kids who are smoking cannabis are more likely to have a difficult time in school. They tend to have lower grades, lower test scores. They're more likely to be absent or truant or drop out. They have a reduced likelihood of graduation. But other studies challenge the idea that it's specifically cannabis that's causing this, and instead point to other factors like sociodemographics. Like maybe there's a common liability that underlies both cannabis use and educational underachievement. And so obviously it's a complex interaction, and we can't just say that it's cannabis, but that's where we are. Another effect is on motivation. There used to be something called the amotivational syndrome back in the, I want to say 80s, and this sort of stereotypically involved a young adult who lived in their parents' basement and played video games and didn't have a job and didn't finish school and just sort of underachieved chronically and smoked a lot of pot. We sort of debunked this idea of an amotivational syndrome, but we do have animal data. For example, this pothead rats are up to the task, but just don't feel like it. I just like this idea of pothead rats, but there is some evidence that there's an apathy or a diminished ability to concentrate, to follow rules, to learn new material, that there's a decreased motivation to perform. And we especially see this on more challenging cognitive tasks, that teens may be more quick to give up on trying to learn, this algebra or calculus problem. And in the animal literature, what we've seen is that repeated doses of cannabis. So if you repeatedly give doses of cannabis to generally rodent models, it reduces motivation for reward-related behavior, that other things they were doing to get rewards become less important because the cannabis becomes more important. And so how might this translate into adolescents or into humans is that the drive to smoke cannabis might replace that drive to engage in goal-directed behavior like schoolwork and studying and graduating and achieving. And so in that way, it can definitely lower motivation. And then there's some risky decision-making. Teens lean toward risky decision-making anyway, and cannabis can certainly disinhibit and increase the likelihood of them engaging in risk behavior. So things like trying other substances, they may be more likely to say, try mushrooms. I mean, why not? Engaging in risky sexual behavior like unprotected sex or things that they might not have tried if they weren't high. And then probably, a really big thing is driving while under the influence. So 2 in 5 teens report or admit having driven after smoking cannabis. Many teens don't consider cannabis use to be a distraction to their driving. I feel like that's not super different than alcohol. Most people who drive after drinking don't think they're too drunk to drive. We see the same thing with cannabis. And more specifically to teenagers, teen passengers report being less concerned about driving with someone riding with a driver who's used cannabis versus one who drank alcohol. They tend to think that riding with a drunk driver is much more dangerous than driving with a high driver. And research is showing that's probably not really the case. And then finally, let's talk a little bit about other psychiatric disorders. So certainly studies have Most studies of cannabis and depression and anxiety haven't really included adolescents as a separate group. They're typically thrown in with adults and not analyzed separately. Gobi in 2019 did a really big meta-analytic study of 11 studies specifically on adolescents and looked at folks whose cannabis use was assessed prior to the age of 18 and looked at depression, suicidal ideation, and behavior in folks from ages 18 to 35. So this is a really strong study, and what her results showed was that if you use cannabis use prior to age 18, where am I? There's an odds ratio of 1.37 for depression. And what this means is that there's a 1.37 increased chance of developing depression if you've used cannabis prior to age 18. 1.5 more times more likely to experience suicidal ideation, and 3.5, almost 3.5 times more likely to make a suicide attempt. In terms of anxiety, cannabis use is associated with the development of anxiety symptoms, and this is especially true for girls compared to boys. And we also know that long-term users are more likely to develop social anxiety than teens who are not using cannabis more regularly. Girls with cannabis use disorder have higher rates of anxiety and mood disorder. Girls tend to have higher rates of these disorders anyway, but it's definitely exacerbated with the cannabis use disorder. And we also know that teens who use cannabis at earlier ages tend to develop issues with alcohol, nicotine, and other substances, and are at higher risk of developing other substance use disorders in addition to cannabis use disorder. And then finally, looking at psychosis, teen cannabis use has been consistently linked with psychotic disorder, and that has become more true as these higher potency products have come onto the market. And what studies have shown is that the earlier the age of cannabis onset use, the earlier the age of onset of psychosis. And one study by Nora Volkoff, who's actually the head of the National Institute on Drug Abuse, she studies, onset of psychotic disorder and cannabis use, and she has reported that use of cannabis before the age of 15 can hasten the onset of a first episode by 2 to 6 years. So you'll see that onset of psychosis much earlier. So the association between cannabis use and psychosis is stronger, like I said, if it's earlier use, and this is use by age 15 compared to 18. If the use is frequent and heavy throughout adolescence, and if there's use of high potency products, that increases the risk of developing schizophrenia by 6-fold. So this is not insignificant. Another recent study showed that any use of any use of cannabis could increase the risk of psychosis 2-fold, and went so far as to say that any use of cannabis might be accounting for 8 to 14% of cases of psychosis in teenagers. And whether or not it causes new cases, I think it's more likely that it triggers an earlier onset, or perhaps the expression of psychosis was in someone who has a predisposing risk factors for developing psychosis. But definitely cannabis is going to make it worse if there is a psychotic disorder, right? Actually, I shouldn't say it quite so strongly. There is some evidence that it can enhance acute cognitive functioning in some people with schizophrenia, but overall, it has more of a negative impact on course and response to treatment. Okay, so let's shift over to talking about screening and assessment. I think the easiest screener to use is the CRAFT, and this is specifically for adolescents. It's easily memorized. It's only 6 yes or no questions. You can do it in any kind of interview or exam that you're doing. It covers both alcohol and drugs. And it's easy to remember. So CRAFT is the car. Have you ever ridden in a car driven by someone who is high? Do you ever use drugs or alcohol to relax or feel better about yourself? Do you ever use drugs or alcohol when you're by yourself? Do you ever forget things you did? Do any family and friends tell you should cut down, or do they express any concern about your use? And have you ever gotten into trouble while using? And so trouble for a teen is going to be your parents caught you, the security officer at school caught you, or a teacher caught you. So you can see why this is scaled down for adolescents. A lot of them who aren't driving are still driving in car, or who are still passengers in cars driven by someone who may be high. And so that's why this works well for teenagers. If you get 2 or more of yeses on this, that is a kid who is at risk that probably needs a little bit more of an assessment. And if you're doing a basic substance use assessment, you want to ask about their age at first use and last use. You want to know their patterns of use, how many days per week, how much are they using each time they're using, how are they using it, are they vaping, are they dabbing, are they smoking joints, what strains. And most teenagers I run into are pretty sophisticated. They'll know that they have a 20% indica strain or they have a 30%. So I would get all that information, find out when they use most often. Is it weekends, summer vacation, when their parents are away? Just get an idea of how they're using. If they've had consequences of use already, are they getting sick all the time? Are they losing friendships? Are they grounded all the time? Like, what are some of the problems they're having? You want to know if they are physiologically dependent, meaning are they having withdrawal symptoms? Are they experiencing loss of control of their use? If they've been in treatment, what kind was it? Was it inpatient, outpatient? What was the outcome? You always want to know if there's family history of substance use issues, not only because you want to gauge sort of the genetic part of it, but also what kind of family support is there? If mom and dad are always getting high in the garage, what kind of support are they going to have for their kid getting treatment? And you always want to know the use status of peers, because that is always the single biggest risk factor for a teen to use cannabis or any other drug if they have the opportunity, right? Adolescent drug use is all about opportunity. So if they have cannabis using friends, they are going to be more likely to struggle with stopping. So the 4 Ps, I like to call this, is building up to screening questions. Those of us who work with teenagers pretty regularly, you have half of them who can't wait to tell you how much they use. They brag about it. Sometimes you have to sort of cut in half what they say they're using. I had a kid who told me that he smoked 10 blunts a day, which I thought was sort of physically impossible because there's just not enough time during the day to do that. And then you also have the kids who really don't want to tell you, either because they don't want their parents to know or they just don't want to tell you. And so I think building up to screening questions is always less threatening to ask about past behavior and other people's behavior before you ask about their own current behavior. So you might ask about, have you ever experimented? Have you ever tried this? Do your parents use it? Do any of your friends use it? And then you get to, are you using? You want to be very accepting and judgmental about what they're telling you. And oftentimes you want to make normalizing statements. Sometimes people who are really stressed or can't sleep often, take a hit off a joint before they go to bed at night and helps them sleep. Have you ever done this, or have you ever thought about it? So you make slightly normalizing statements about it. And sometimes that can help someone who's reluctant to talk about it feel a little bit more comfortable talking about it. So the DSM criteria for a substance use disorder, as I said, there's loss of control. So there's 3 basic areas: loss of control, physiological, and then consequences of use. And you have to meet 2 of these to get a cannabis use disorder diagnosis. So loss of control means that you're using larger amounts over a longer time. You've tried to cut back, but you can't, or you're struggling with it. You spend a lot of time either getting a hold of cannabis, using it, recovering from the effects of it. You're not doing other things because you're busy being high. So you're not going to class, you're not hanging out with friends, you're not doing things with your family, and you report craving it when you're not using it. And the physiologic is tolerance and withdrawal. So withdrawal, we all already covered. Tolerance is when you need more of it to get the same effect, or if you're using the same amount, you're not getting the effect that you used to. You've gotten tolerant to it. And the consequences is, you're using it when it's dangerous. You use it before you drive, or you ride your bike in traffic, or you go swimming at night while you're high. So you're using it hazardously. You're having social problems or interpersonal problems. Your boyfriend's always mad at you, or your friend, you no longer have friends because they don't want to be around you when you're high. Neglecting major roles, not going to school, not going to work, not contributing to the family, and you continue using after significant problems. And severity is related by the number of symptoms they meet. So 2 to 3 of these would be a mild disorder, 4 to 5 would be moderate, and 6 or more would be a severe disorder. So one thing to remember is that teens might not meet these criteria because those are adult criteria and they're designed for adults. And so when you're trying to decide if a teen has a disorder, you might look at things like, are they having a hard time sleeping? Are they getting moody and agitated and disruptive if they can't get high? Are they depressed? Are they not going to school? Has school performance dropped off? Are they reporting anxiety symptoms? Are they having rapid changes in mood or getting hostile if they're in withdrawal? Have they shifted to new friends because they had to find friends who would smoke pot with them? They're not introducing these new friends to their parents because their parents are going to see that these kids, may not be the kids they want them hanging out with. Are they sneaking out, lying? Are they locking the bathroom door? Is money going missing in the house? So you might be looking at things like this that are more specific to teens. Intervention will be pretty quick because we don't have a lot. There's no FDA-approved pharmacotherapy for cannabis use disorder. There have been a couple of studies done showing that N-acetylcysteine, or NAC, which is a cysteine prodrug that's found over the counter in CVS. I actually saw it in Kroger the other day. 1,200 milligrams twice a day for 4 weeks has been shown in 2 different studies to reduce craving and use of cannabis only in adolescents. It does not seem to work for adults. But those studies were combined with behavioral therapy. It wasn't just the N-acetylcysteine, but I wouldn't hesitate to have a teenager try NAC. We have behavioral and psychosocial approaches. Most of the evidence we have for efficacy come for CBT or cognitive behavioral therapy, motivational or MI or MET approaches, and then contingency management. Overall, we know teens do better with any kind of treatment than without. And part of what I want to tell you, so these are some of the evidence-based approaches. I just named them. So CBT, group or individual. CBD, if you can combine them with motivational and contingency, is your best bet. There's also different kinds of family therapy. I won't go into the differences because I think they're more alike than different. But what you need to know is that they are efficacious, but only moderately so. They might be initial decreases in use, but about 2/3 of them are going to continue to experience problems later on. Many never actually become abstinent, and many of them relapse. And so we overall will say they're effective, but only modestly. And in the interest of time, I'm going to go quickly here. One big study looked at these 5 different treatments for cannabis use disorder. So they evaluated these 5 outpatient treatments. So a motivational plus CBT, 5 sessions or 12 sessions, or adding family support, or just family therapy, or community reinforcement, which is all of these things together. And here's what I want you to see. They started out here at treatment. After treatment, use came down. There is no difference among any of these treatments. So none of these treatments is much better than any other. So any treatment versus no treatment. Working with teens in treatment, teens don't seek treatment on their own. Usually they're pressured into it by a parent or a court or a school or a probation officer. Teens don't see cannabis use as a problem. And so their motivation to quit is really low. Their efforts to quit is low. I would urge you to consider harm reduction rather than abstinence. If you start out with a kid and say you really need to stop smoking pot, they're going to just stop listening to you. So what you might say is, okay, so you're smoking pot 4 times a day. Could we maybe stop using in the morning when you're about to drive to school? Right? So most kids will be able to agree to maybe considering stopping one of those. Maybe they want to smoke at night when they're done with homework. They might want to smoke after school. But if you can get them to stop smoking before school, before they drive, that would be a harm reduction approach. And they're going to be more open to hearing that than you saying you have to stop entirely. Few achieve abstinence after a single episode. And I would urge you to consider, if you're seeing kids on an outpatient basis, they are probably still using while you're treating them. So overall, it's not benign. Rates are really high. We know that brain development during a time of vulnerability, cannabis use is not a great thing. There's a risk of developing a cannabis use disorder, other substance use disorder. We know that there are acute cognitive effects, mental health effects, definitely school performance effects. They're less likely to attend college. They have less career success, lower salaries, and report being less happy with their family and peer relationships. So if you can delay initiation of cannabis use, ideally into the 20s, but if you can say to someone, can you wait till you're 18 or 19? You want to discourage regular use. And remember that the legal definition of adult doesn't correspond to brain development. Just because you're 18 doesn't mean your frontal lobe is all done being pruned and is not fully finished. And I think I'll stop there. Thank you for your attention and would love to hear any questions.
Thank you so much for that informative presentation, Dr. Lundahl. There was a lot of great information there. So now we're going to open it up for questions, and we do ask that all questions be submitted through the Q&A function, which can be found at the bottom of your screen. And while you submit those questions, I have a few reminders to share. First, this webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. Also, this live webinar has been approved for 1 social work continuing education clock hour, 1 specific MCBAP credit hour, and 1 credit hour of CME. If you're requesting any of these continuing education credits, please fill out our evaluation form with your name and email and follow the instructions specific to the type of credit you're requesting. The evaluation link will now be shared in the chat. If you're unable to access the feedback survey through the chat, the survey link will also be emailed out to all webinar attendees later today. All right, and now we're going to move on to questions. We did have a couple questions about the high potency cannabis. So one person is asking, how long will it take to start seeing research on that high THC content?
It depends on when NIH allows us to use higher potency. Those of us who do marijuana research can only use cannabis that comes from a DEA approved facility. And right now, the only one that has cannabis available is NIDA. And so the highest potency I've been able to get from my studies is about 12%, which is like a third of what you can get at a dispensary. So until the government, I think, I shouldn't say it this way, but until the government allows researchers to gain more access, we're not going to see research on those, but we're getting there, I think.
Wow, okay, thank you.
Mm-hmm. I'll probably never get another government grant, having said that in public. But anyway, go ahead.
We did get another question. Is butane hash oil used to make edibles?
That depends. I mean, some people just put pot right into brownies, right? That's the old school method, pot brownies. But some of the products that you'll see in dispensary, those are concentrates. Yes, those are oils and just they're distillates and extracts. I don't know that's always butane hash oil. There's a lot of different ways to extract the cannabinoids out of the plant.
Great, thank you.
Mhm.
Another question about those high potency cannabis products. Do different forms of extracts have different potencies? For example, is wax more potent than shatter?
They definitely have different potencies. And I wouldn't say that it's wax versus shatter. I think, although actually I would say shatter is probably more potent, but it depends on the extract that the concentrate that you're using. So a concentrate can be anywhere from, 15, 20% to 90%. So it's not really the form, I think.
Okay, good to know. Okay, so Terrence asks, should there be a prohibition against prescribing stimulants on patients who use cannabis? The American Association of Pediatrics says no, but it's getting more complicated.
Yeah, I'm not a physician, so I'm not going to say anything medically, but I know that there are drug interactions that we need to be increasingly aware of. I don't know if there's a direct interaction with stimulants, but it is complicated. I would agree. Yeah.
And then someone also asked about hearing a lot about teens and college students using marijuana gummies to fall asleep when it's time for bed.
Mm-hmm.
So, and one college student said that her doctor actually recommended that. So is that something that you're seeing as well?
Yeah, I mean, I don't know if it's all doctors or a lot of doctors recommending. I do see a lot of college students who say that they are using gummies to fall asleep. And if you think about it from a harm reduction standpoint, that's probably the safest way to use it, right? You're in bed, you're about to go to sleep. If you're going to use cannabis, that would probably be or THC, that's the safest way to do it. I don't know if doctors are recommending it, but I think CBD is definitely being recommended for sleep, for sure.
Okay. Okay, and is there a difference in risk of psychosis between males and females in teenagers? Is that something that's been studied?
I don't know that that's been studied. I don't know of a difference. Actually, I think rates tend to be higher in men and boys in general, or men in general, but I don't know about the cannabis risk. That's a good question.
Okay. Thank you. Okay. This person asked, you said vaping doesn't use heat, but I missed how the cannabis is vaporized. Could you expand on that a little bit?
Oh, yeah, it's heated, but it's a heated coil through a battery. It's not combusted. It's not fire. So it's still heat, but it's not combustion.
Okay, thank you. Marianne is wondering if there are any cessation programs for teens, like the program Not on Tobacco.
I am not aware of any, but I would be surprised if there weren't. A really good resource would be to go on the NIDA.gov website, and there's a whole area on teens, and I would imagine there are apps and things like that that are very teen focused on their phones and all that they could access. I would think there might be something.
Okay, great. That's a good resource for people. And there's another question about, can you go over how marijuana relates to bipolar and schizophrenia? I know you mentioned it briefly earlier.
How it relates to it, I mean, I think there are correlational studies that show, and by correlation, what I mean is that they seem to go together, but they're not necessarily causal. We don't know that it's actually caused by cannabis use, but they are associated, right? There are higher rates of bipolar disorder and schizophrenia when there's, you tend to see cannabis use in that background. But I think it's difficult to tease those apart because those are very complicated disorders. They're multifactorial. My guess would be that, I don't know how many spontaneous cases of a bipolar or schizo or psychotic disorder would arise just from use of cannabis if there's not a predisposing underlying genetic or familiar or whatever kind of factor that's already there. So those data are pretty much, they're correlational, they're not causal, but there is definitely a link for sure.
Okay, thank you. And let's see. Patricia is asking, how young are you seeing for use of cannabis? And they said that they've had elementary school students talk about cannabis use.
Yeah, I would say in the last maybe 10 years, the youngest I've seen is around 10 or 11. They already know quite a bit about it. And generally it's because, someone in their household is using it and it's something that they talk about. So yeah, it's definitely pretty young, getting younger. Yeah.
All right, and I think we'll have time for just one more question.
Okay.
Elizabeth is wondering if the way that you're vaping or using concentrates affects how dangerous it is. So is it more dangerous when you vape it versus other modes of using?
Well, I mean, if you're using a concentrate, you really can pretty much just vape it or dab it. Dabbing it would be a little more dangerous because you're getting all of it at once versus vaping when you're sort of taking, a hit at a time. But I just think these concentrates are sort of off the charts scary. Like I said, if people were smoking 1 to 2% THC, right, in the 70s and 80s, and now we're up at 98, 99% THC, I mean, that's insane, really, that those products are out there.
Yeah, definitely concerning. All right. Well, thank you so much, everybody, for attending the webinar, and thank you, Dr. Lundahl, for your presentation. We would greatly appreciate everybody's feedback so that we continue to improve our webinar offerings. There will be a link in the chat to complete our feedback survey. And as a reminder, our live webinar has been approved for 1 social work continuing education clock hour, 1 specific McBAP credit hour, and 1 credit hour of CME. And again, if you're requesting any of those, please fill out the evaluation form with your name and email. And if you're unable to access the feedback survey through the chat, it will be emailed later today. This concludes our 2024 Cannabis in Practice webinar series. We hope that you found this webinar series informative and interesting. For recordings of this year's presentations and for previous year's webinars, as well as more information, visit our main marijuana page at washtenaw.org/marijuana. Thank you so much again, Dr. Lundahl, for closing out our webinar series, and thank you everyone for attending.
Thank you.